that, we will now switch to our plenary speaker, Dr. Marzia Pasquali. Dr. Pasquali is a professor of pathology. She's also the program director of the ACGME Accredited Fellowship Program in Clinical Biochemical Genetics at the University of Utah School of Medicine, and she is the section chief and medical director of biochemical genetics at ARUP Laboratories. So Dr. Pasquali, if you are on the line, you can go ahead and start sharing your screen.
Can you see my screen?
Yes.
Okay. Thank you for inviting me to share my experience with cerebral creatine deficiency syndromes. It's very encouraging to see all the work that has been done for therapy. But bottom line, we need to identify the patients first. We know that early treatment is a key for an effective outcome, for a good outcome. So let me quickly go through the cerebral creatine deficiency syndromes, even though after these 2 days, I think we know, everybody knows what they are, but these are disorders caused by defects in creatine synthesis or transport. They are characterized by intellectual disability, autistic-like behaviors, seizures, speech and cognitive delays. They can also present as moderate intellectual disability, attention deficit disorder, or, should not have gone ahead. So there are typically, initially these disorders were identified because of the lack of a creatine peak in the when MR spectroscopy of the brain was performed. There are, however, biochemical tests that can be used to diagnose creatine deficiency syndrome. And as we have heard, newborn screening definitely is effective. Can we, I'm not sure why this is proceeding by itself. Yeah, let's go back. Okay. Let's look at the function of creatine. Creatine serves as an energy shuttle between the mitochondrial sites where ATP is produced and the cytosolic sites where ATP is utilized. And again, creatine is phosphorylated to phosphocreatine by mitochondrial creatine kinase. And phosphocreatine transfer the phosphate group to an ADP molecule to a creatine kinase in the cytosol and forming ATP. Now, how is creatine? How do we get creatine? Creatine, there are two sources of creatine. One is from the diet and one is through a biosynthetic pathway. The biosynthetic pathway starts with arginine and glycine, and the enzyme arginine glycine amidinotransferase or AGAT, which convert these two substrates into ornithine and guanidinoacetate. This reaction, this is the first step in the biosynthetic pathway of creatine. Second step is the conversion of guanidinoacetate to creatine. This occurs through the enzyme guanidinoacetate methyltransferase and the use of S-adenosyl methionine as a methyl donor. Creatine then needs to be taken up by the brain, the muscle, in order to function, to perform its function. And this is done through the action of a creatine transporter. Creatine is then, and phosphocreatine are then converted into creatinine and excreted in the urine. So a block in an impaired function of one of the two enzymes involved in the biosynthesis of creatine will lead to a reduced concentration, reduced synthesis of creatine. In the case of GAMT deficiency, we also have an accumulation of the substrate guanidino acetate. When you have an impaired function of the creatine transporter, the synthesis is not impaired. So guanidino acetate and creatine levels are going to be normal. However, because the creatine transporter is the one that's used by the kidney to reabsorb creatine, if it's not working, creatine will be lost in the urine, and so the concentration of creatine in the urine is going to be higher. This table shows the pattern of metabolites that we see when we use biochemical tests for the diagnosis of this syndrome. So in AGAT deficiency, and again, AGAT is the enzyme involved in the first step of the biosynthesis of creatine, we will have low creatine and low guanidino acetate in plasma. In GAMT deficiency, we will see a low creatine and a high guanidino acetate in plasma. In creatine transporter deficiency, the concentration of creatine and guanidino acetate in plasma are going to be normal, but the urine creatine, once it's normalized for creatinine, is going to be very high. The diagnosis is then confirmed usually by molecular testing. Enzyme assays and transporter assays can be helpful, but are not readily available, at least in a clinical setting. So let's look at each condition one by one, and let's start with AGAT deficiency. Again, to reiterate, blocking arginine glycine transferase will result in reduced concentration of the product of the reaction. The immediate product is guanidino acetate, and the downstream product is creatine. So this condition, again, is inherited as an autosomal recessive disorder. The incidence is unknown, is probably the rarest of the three conditions. Very few patients have been reported to date. How low are these concentrations of guanidino acetate and even creatine? The data that I'm going to present today are a summary of clinical data that we have accumulated in the last few years of testing for creatine deficiency syndrome. The patients that we have seen with AGAT deficiency, and again, the number is very small, had very low guanidino acetate concentration. They were either 0 or very close to 0. And this slide shows in a black circle the concentration in unaffected controls. The pink circle represent a patient with AGAT deficiency. You can see that if you look at the plasma, for both guanidino acetate and creatine, the concentration is markedly reduced, and there is a pretty good separation between the unaffected controls and the patient. When we look at the urine, we start seeing a little bit more overlap with the unaffected control. And if we expand the region of the low concentration, you can see that the urine as a specimen type is not as specific as the plasma in identifying this patient. And again, we have overlap with the potential for false positive result, identifying the false positive result. So a take-home message for AGAT deficiency: plasma is the most informative specimen type for diagnostic purposes. Moving to the second step in the biosynthetic pathway, which is the one catalyzed by guanidino acetate methyltransferase. A block in this enzyme will result in accumulation of the substrate guanidino acetate and a reduction of the product, which is creatine. Again, GAMT deficiency is inherited as an autosomal recessive disorder, and we have that both the lack of creatine and the accumulation of guanidino acetate affect the brain. The incidence, estimated incidence after the latest identification through screening is probably around 1 in 250, 275,000. And again, what are the values that we are seeing in patient identified with GAMT deficiency at diagnosis? Here I've shown you a range, and again, compared to the normal, to the reference range, there is a pretty good separation between the patient and the unaffected control. And this graph showed this point that I think it's very clear that the guanidino acetate concentration in plasma is markedly elevated compared to unaffected control. In this slide, the blue circle represents patient with GAMT deficiency, and the values are the values at diagnosis. And again, even for the creatine, creatine concentration at diagnosis in all of this patient is very low. The same thing that we observed with AGAT deficiency, urine is not a specific specimen type for the diagnosis of GAMT deficiency. But in this case, instead of having the risk of false positive, we will have false negative results. So you can see here that there are a few patients with a value for in the urine of guanidino acetate that's overlapping with the normal population. And this is not an artifact of age groups, of grouping, having bins by age group. You can see that this is, even when you're using a continuous model, they are still overlapping, and the same is for creatine. In the next slide, I wanted to show you, so we have the same data, but I have added values represented by the red circle from a patient with GAMT deficiency on the treatment. And on average, we can see that the treatment lowers the concentration of guanidino acetate in plasma, except for a few exceptions. The creatine concentration is much higher than the control. And again, one more time, when we are looking at the urine guanidino acetate, there is overlap for many patients with the normal population, and the same for creatine. So again, even for GAMT deficiency, plasma is the most informative specimen type for diagnostic purposes. The third condition is creatine transporter deficiency. And as I said before, when we have creatine transporter deficiency, the synthesis of creatine is not affected. It's only the uptake of creatine by the tissue and the organs that need the creatine that's impaired. So this condition is an X-linked condition. And again, the incidence, I don't think we have some good figure for the incidence yet. It might be more frequent than GAMT deficiency. Looking at our data, again, this slide shows you a diagnosis. Unfortunately, I only have one patient with values a diagnosis, but you can see that the plasma creatine and guanidino acetate were normal, or in the case of creatine, was even a little bit above the normal range for age. But the creatine-creatinine ratio, again, creatine normalized for creatinine was high. And I'm going to show you in the graph, because that ratio depends on age. So I couldn't put all the reference ranges. Again, in this graph, the black circle are controls, the green circle are creatine deficiency, creatine transport deficiency patients after they have been diagnosed, so on therapy. And the blue circle represents one patient identified in the last year with creatine transport deficiency. Again, guanidino acetate and creatine in plasma are within the normal range. Their creatine is high, of course, in patients on treatment. Guanidino acetate in urine completely overlaps with the unaffected control as expected. But when we look at the creatine in urine normalized for creatinine, there is, again, very clear separation between the patients with creatine transporter deficiency and the unaffected control. So in this case, urine is the most informative specimen type for diagnostic purposes. So having said this, when diagnostic workup is done on a patient suspected of a creatine deficiency syndrome, you need to look at both, because you don't know which one condition is going to be. So you need to look at both the plasma and urine, but keeping in mind that for GAMT and AGAT deficiency, a urine guanidino acetate, especially for GAMT deficiency, a urine guanidino acetate in the normal range does not exclude the condition. You really need to focus on the plasma results. And for the creatine transporter deficiency, of course, you need to focus on the urine result. Now, I want to talk about newborn screening. And again, the definition of newborn screening is a public health activity aimed at the early identification of conditions for which timely intervention can lead to the elimination or reduction of mortality, morbidity, and disability associated with this condition. So when you read this definition, you know that this applies to cerebral creatine deficiency, at least to some of them. And I want to talk specifically about the story of a newborn screening for GAMT deficiency. This started with a family that had 2 children, and they saw in firsthand the impact of early treatment on the outcome. Then a physician and the screening joined the family, and the physician was determined to allow all babies with all the patients with GAMT deficiency to be identified early, so to improve their quality of life and their outcome. And then a laboratory got involved, and it so happens to be my laboratory, and my laboratory always has always operated under the motto, let's give the patients the best chance that they can get. So we joined the forces, and we demonstrated that newborn screening for GAMT deficiency was feasible. And we were able to integrate the analysis of guanidino acetate and creatine in our routine newborn screening method. And we were able to detect these two analytes simultaneously while doing the analysis of amino acids, so carnitine and succinylacetone. No additional sample was needed. And the cost of the screening, the additional cost of the screening is really very, very low. It's just the cost of the reagent. We used as a primary marker guanidino acetate, and as a secondary marker, the ratio guanidino acetate creatine. Why do we need a secondary marker, a ratio? Because this increases the specificity. These are data from our pilot study that we did. We analyzed 10,000 de-identified blood spots, in addition to blood spots that are from patients confirmed to have GAMT deficiency. The red circle here are from the results from the patient with GAMT deficiency, and the black circle again are the control. The vertical dashed line represent the cutoff for guanidino acetate. As you can see, if we apply only the cutoff for guanidino acetate, we see several samples that will have an increased value, a value above the cutoff that was set. By using a ratio guanidino acetate creatine, which is represented here by the horizontal dashed line, we are increasing the specificity of the screening and reducing the false positive result. In addition to use this the ratio guanidino acetate and creatine, we also used a second-year test. We introduced a second-year test. So all samples with an elevated guanidino acetate and ratio guanidino acetate creatine were subject to second-year testing by liquid chromatography tandem mass spectrometry. And this was to get rid of the possible interferences that were that had the same signal as guanidino acetate, and only those with an abnormal second-year test were proceeding to confirmatory testing. Now, when we did our pilot study, none of only the sample from patient with GAMT deficiency had an abnormal second-year test. So we decided, thanks to the Utah Department of Health, that was fully on board with implementing this screening. We went live and started the statewide screening for GAMT deficiency. Once we started screening the entire population, we realized that we had there were some patients, some babies with an elevated guanidino acetate on the second-year test. But most of these babies were in the neonatal intensive care unit. And when we looked at these babies, we noticed that there was a positive correlation between the level of guanidino acetate and the level of arginine. And of course, this is not surprising since arginine is a precursor of guanidino acetate. This shows you what we have seen. Again, when we looked at the ratio, we thought that the ratio arginine guanidino acetate could be a potential an additional marker to reduce false positives. There were not that many, but to reduce false positive even further. As you can see here, the open circle represent patients with GAMT deficiency, and the black circle represent unaffected individuals. So this was used also to reduce the false positive rate for GAMT deficiency. Now, at this point, so this table shows the summary of the results of the screening up until February. And as Heidi mentioned before, Utah, we are no longer doing the newborn screening for the state of Utah. The Department of Health is performing the newborn screening, and they have switched to a non-derivatized method. At the same time, other states have implemented statewide screening, like New York State. And these are the results, which are very important to me, because these results show that no matter what type of screening you are doing, whether you are using a derivatized or underivatized method, no matter what type of algorithm you are using, when we did the screening, it was very easy for us to do a second-tier test immediately. As soon as we saw an elevated guanidino acetate. We didn't repeat any sample, but we went straight to the second-tier test. But other laboratories which do not have in-house the ability to do the second-tier test, they can follow a different algorithm. So New York uses also a DNA reflex test. So no matter how you do the screening, and no matter how what type of algorithm you use, you can detect this condition. And the false positive rate is very, very, very low. Even if we calculate the positive rate based on 23 positive, screen positive, the false positive rate will be 0.004% perhaps. So this screening can be implemented by all laboratories, and again with the minimum impact on their cost. So what have we learned? So far? We have learned that I don't know if this presentation has a mind of its own. Guanidino acetate can be within the normal range in urine of patients with GAMT deficiency, even at diagnosis. So measurement of guanidino acetate in urine to diagnose the GAMT deficiency can lead to false negative results. Therefore, it's not the specimen type of choice for diagnostic confirmation of GAMT deficiency, especially in newborns. Plasma should be used. Low guanidino acetate in urine is not specific for AGAT deficiency, and this can lead to false positive results. So again, for diagnostic confirmation of AGAT deficiency, plasma should be used. And Creatine in plasma of patients with creatine transporter deficiency can be normal or even mildly elevated. Urine is the specimen of choice for the creatine transporter deficiency. We know now that newborn screening is feasible and effective for GAMT deficiency. And I think that soon we will be able also to implement newborn screening for AGAT deficiency and perhaps even for creatine transporter deficiency. And the specificity of newborn screening for GAMT deficiency can be increased by using ratios such as guanidino acetate over creatine and guanidino acetate over albumin. And I would like to acknowledge everybody who has been instrumental in collecting all the data and performing the analysis and bringing the newborn screening where it is. At ARUP, our biochemical genetics newborn screening lab, our research and development lab, and the information technology department, the Department of Health, the newborn screening and follow-up program, University of Utah, the Division of Medical Genetics and the Metabolic Clinic, and last but not least, the patients and families, the Association of Creatine Deficiency, and again, all the patients and families, because they are really the true inspiration of all the work that we do. Thank you.
Thank you so much, Marzia. That was a wonderful presentation.